Primali, just can you on your video as well? Dishan, can you take a photo before others join?
Sure, man. Sure.
Primali, on your video.
Can you all see now?
Ah, yes. Yes, Dishan.
Primali, I also join. I could
okay.
join.
Yes, I
Can
can
on
see.
your video? Ah, okay.
I can't open the video. Oh, I think it's Dishan.
Make him panelist.
Sure, man.
Must be panelist, otherwise you can't talk.
Yeah, I'm a panelist, but I can't start the video. I don't know why. Because the host has disabled, yes.
No.
Ah, yeah, now can. Can you see me?
Yes.
Madam, the screen sharing is ongoing. Shall I close for a while? Is it okay?
Okay.
Start. Good evening, everyone. Welcome to the Senior Registrar Forum of Sri Lanka College of Internal Medicine for the month of November. Before introducing the speaker, may I invite our President, Dr. Suranga Manilgama, to have a word with us. Suranga, over to you.
Thank you, Primali. A warm welcome to SR Forum, Senior Registrar Forum of Sri Lanka College of Internal Medicine. And please join with me to welcome our speaker, Dr. Primali Jayasekara. She's going to speak to us on fungal infections. You all know in our day-to-day practice, we see a lot of fungal infections in our wards, medical wards. So I think this is very important topic to each one of you. And so I invite her to deliver her talk on mycology tips for physicians when what we should know about mycology. And I also thank Professor Primali Jayasekara for organizing and coordinating the SR Forum for Sri Lanka College of Internal Medicine, and also Dishan and the technical team for giving us the support. And once again, I invite everyone to join with us, and also I wish everyone a fruitful session. Thank you very much.
Okay, may I
Thank you,
introduce
Suranga.
the speaker? She's Dr. Primali Jayasekara, consultant mycologist, head department of mycology, MRI. She's the first board certified mycologist in Sri Lanka. I think this topic is very timely topic for us. We had probably last month we had a fungal week as well, because we are seeing a lot of fungal cases. And without taking much time, I would invite Dr. Primali Jayasekara to deliver her speak. Over to you, Primali.
Thank you, Primali. Hope you can see.
Yes. We can see and we can hear you. Yeah, you can continue.
Good evening, everybody. First, I would like to thank Sri Lanka College of Internal Medicine for giving me this opportunity, the President, Suranga, and the Council. Today, I am going to talk about mycology tips for physicians. So we will start with mucormycosis epidemiology. Though the literature says it's a rare disease, it's no longer a rare disease for Sri Lankans. It's an emerging and opportunistic fungal infection with high morbidity and mortality, and it is caused by filamentous fungi belonging to family Mycorrhizae and order Mycorrhizae. So there are 92 species which can cause human infections. These fungi are ubiquitous in nature, and we get the infection mainly by inhaling the sporangiosperms and occasionally through ingestion of contaminated food or traumatic inoculation. And there are some common species which causes mucormycosis like Rhizopus, Rhizomuco, and so on. So in Sri Lanka, it's Rhizopus, it's the commonest one, as well as in the rest of the world. So the distribution of different species varies among the different geographical regions. And these fungi are found on organic substrates, decaying fruit and vegetable matter, etc. So you can see here the causative agents. The commonest is Rhizopus, as I told you earlier. So this is the worldwide distribution of mucormycosis. You can see Sri Lanka, they have reported as where the numbers are not reported, but still we have the infection. So the prevalence, incidence, and clinical manifestations, the prevalence varies between developing and developed countries between 0.01 to 14 per 100,000 population in Europe and India. The incidence is rising due to growth of the immunocompromised patient population, increased awareness, and development of diagnostic techniques. Clinically, there are 5 types of presentations, like we all know about rhinoorbital cerebral mucormycosis, pulmonary mucormycosis, which I am going to talk more today, cutaneous, gastrointestinal, and disseminated mucormycosis. So this is the Sri Lankan situation. You can see I have gathered only data from 2018. From 2018 to 2020, we have rhinoorbital cerebral mucormycosis around 40 cases and pulmonary mucormycosis 1 to 5. But in 2021, with the COVID-19 Delta variant, the numbers rise massively. So it became 139 for rhinoorbital cerebral mucormycosis, and there were 2 pulmonary mucormycosis cases. And since then, the numbers have been increasing, and especially the problem is increase in the pulmonary mucormycosis cases. Now, mind you, all these data are from my department, that is from Department of Mycology MRI. There are another group of patients which has to be added to this list where the histopathologists are diagnosing, because there are some instances where when the clinician, especially the pulmonary mucormycosis patients, when the respiratory physicians are not thinking, or when they are suspecting, when they are not suspecting mucormycosis or fungal infection, they are not sending us samples. So they only send the samples to histopathologists. So there are more than this, the actual numbers are really more than this. So we have to be vigilant how to manage these patients and not to miss any of these patients. So risk factors for pulmonary mucormycosis. The literature says the number one risk factor is neutropenia, but in Sri Lanka, the number one risk factor is uncontrolled diabetes and with or without ketoacidosis. So if the patient has got uncontrolled diabetes or any of these, you have to be think of pulmonary mucormycosis. And the others are solid organ or allogeneic stem cell transplantation, prolonged high-dose glucocorticoid therapy, leukemia and other hematological malignancies, cytotoxic chemotherapy, and chronic lung diseases. So the mode of transmission, the spores are inhaled and then deposited in the nasal turbinates. Then the patient can get rhinoorbital cerebral mucormycosis. When these spores are deposited inside your lungs, they can reach the distal alveoli space and begin to germinate there. Then the host immune system, the macrophages and neutrophils, can phagocyte this conidia. And this process is inhibited by glucocorticoids and neutropenia. So the host neutrophils attack hyphal forms and acquisition of free iron supports hyphal proliferation. So this step is impaired by glucocorticoids, neutropenia, hyperglycemia, and iron overload. So this is where the hyperglycemia states come. So then now these organisms, these mucorales organisms are angioinvasive. So the angioinvasive growth in tissue with hemorrhage, thrombosis, and necrosis can take place, and that can cause dissemination of the infection. Clinical features, symptoms typically non-specific. Later stages of infection, the patient can present with fever, dyspnea, cough, and chest pain. Rarely, they can present with progressive subcutaneous emphysema, Pancoast syndrome, Horner syndrome, or chronic mediastinitis and bronchial perforation. In pulmonary mucormycosis, you can see a rapid clinical progression, which can be often fatal. Patient survival is dependent on an early diagnosis and treatment. If left untreated, they can be fatal within 2 to 3 weeks. Radiology. Radiological manifestations, mostly non-specific. Abnormal chest X-rays result in more than 80% of patients. So CT findings are consolidation, cavitation, air crescent sign, halo sign, reverse halo sign, solitary or multiple pulmonary nodules or masses. So these are the initial changes that you can see. Bronchopleural fistula, pulmonary artery pseudoaneurysms, lymphadenopathy, and pleural effusion. Cavitation in 40% of cases, but the air crescent sign is uncommon. So cavitation is a later sign. CT findings can alter the management or diagnostic approach in 26% of patients. And air crescent sign, when it is there, it's a poor prognostic sign if surgical therapy is delayed. Higher sensitivity with HRCT is there because you can see the extent of the disease, evidence of the infection earlier than chest X-ray. Right lung is more commonly involved than the left, and there is a predilection for upper lobes, but the cause for this is still unknown. Here you can see a chest X-ray with no infiltration in either sides of the lung. Same patient, HRCT, you can see focal areas of consolidation with surrounding ground glass opacity with a halo sign in the posterior segment here. Here, same patient, increase in size of the previously demonstrated consolidation, which has extended to the visceral pleura, resulting in pleural thickening. Here, well-defined cavitatory lesion within the right upper lobe with the air crescent sign. Nodules of varying sizes are noted around the lesions and the left upper lobe. You can see the nodes here. So this is how you can see the HRCT. Lab diagnosis, early diagnosis, which is essential for successful treatment. Specimens, clinical material, that is a biopsy from necrotic or pale lesions during bronchoscopy, or else you can send sputum ball in sterile screw cap container at room temperature for fungal studies. Please don't refrigerate these samples, because once you refrigerate these samples, these organisms can die. So we will not be able to grow them in our cultures. And the other thing is, it is always better to send us a biopsy sample than sputum or ball, because you can get a good diagnosis with the biopsy sample. And direct microscopy, significant than isolation in culture. You can see wide hyaline non-septate ribbon-like hyphae with right-angled branching. So this is the direct microscopic features that you can see: broad ribbon-like non-septate hyphae with 90 degrees angle branching. Histopathology, again, you can see broad non-septate hyphae. They are wider than Aspergillus species. So for a trained eye, you can differentiate Aspergillus from mucormycosis causing organisms. And branch irregularly, the angle of branching is greater than other organisms and usually 90 degrees. So this is the histopathology slides. Culture specific identification of the causative agent can be made from this, but you have to be carefully interpret that, because now all these organisms are common environmental pathogens or contaminants. So there can be instances where the direct microscope could be negative and the culture could be positive. So in those instances, you have to be very careful with your laboratory report. You have to correlate clinical features of the patient, radiological findings of the patient before coming to a conclusion that the patient is having either rhinoorbital cerebral mucormycosis or pulmonary mucormycosis or any other fungal infection, because most of these pathogenic fungi are there in our environment as a contaminant, environmental contaminant. So the culture could be positive. So to avoid the confusion, the best thing is to write a proper history in the request form when you're sending the samples, so that when there is a when the direct microscopy is negative and when there is a culture growth, we can decide whether this is a contaminant or a true pathogen from the lab itself and issue the report. But when it is not written, we have no idea of what is happening in the ward. So we tend to release the culture report as well. So that is why it is very important to write the patient's history and findings in the request form. So blood culture is always negative. So nasal, palatal, and sputum cultures, when the culture is positive, with a direct negative direct microscopy, most of the time they are common contaminants. If the patient is having diabetes or immunosuppressed conditions, these cultures could be pathogens. So you have to be cautious about that. Serology and molecular tests, no routine tests available to diagnose any form of mucormycosis. So antifungal sensitivity, you can see the first line drug is amphotericin B. It could be liposomal or deoxycholate. You can use posaconazole as a salvage therapy, but never ever use posaconazole as first line therapy because it will not work. So you can see the MIC values are very low for both drugs, for all the organisms. Management, invasive mucormycosis is a medical emergency. Any clinical form, it's a medical emergency. So early diagnosis is based on clinical, microbiological, histopathological, or radiological features is the key for successful management. Controlling or eliminating underlying predisposing factors like diabetes or diabetic ketoacidosis, corticosteroid intake, immunomodulators, immunosuppressant agents is very important. And this can prevent worsening of the disease as well. So removal of the infected debris is very important, especially in rhinoorbital cerebral mucormycosis and cutaneous mucormycosis, because for pulmonary mucormycosis, it's very difficult to do this. So you may have to remove debris several times, and each of the time you have to send them to the laboratory. Because I told you now these organisms are angioinvasive, they can cause thrombosis and necrosis, which will prevent antifungal drug being penetrated to the infected tissues. So that is why this removal of infected debris or debulking is very important. Frontline antifungal therapy with amphotericin B, this is the optimally you can use the lipid-based formulations, but nowadays it is very difficult to find lipid-based formulations and it is very costly. So what you can do is we can go ahead with deoxycholate preparations of amphotericin B. Management of mucormycosis, it's a team effort. So you have to get together and do the management. So this is a circular which the Ministry of Health has issued in 2023, which reveals about surveillance, notification, investigation, and also the management guideline. So you can download this circular and use whenever you all are managing patients. Moving on to mortality, overall mortality is 54%, and the mortality varies depending on the underlying condition and the site of infection. Like if the patient has no predisposing condition, the mortality is around 35%. Mind you, I have seen patients without risk factors who has got mucormycosis. So it doesn't mean that we always have to have a risk factor to get mucormycosis. And diabetes, it's 44%, malignancy is 66%. And among the site of infection, disseminated infections has 96% mortality, whereas pulmonary infections has 76%. Higher survival rates are with the patients with healthy immune status and without comorbidities. Poorest prognosis can be seen in patients with hematological malignancies, stem cell transplant recipients, and patients with extensive burns. Disseminated disease, especially when it has disseminated to central nervous system, the mortality rate is more than 80%. Moving on to a new entity, histoplasmosis. Although we say it is a new entity, it is not, because though Sri Lanka is not in the endemic area, we do have histoplasmosis as well as the neighboring country. So it is caused by a thermally dimorphic fungus. Thermally dimorphic means at room temperature, it's a mold, and at body temperature, it's a yeast. And the infection is caused by Histoplasma capsulatum complex. It's a systemic mycosis. It can infect immunocompetent and the immunocompromised. So that is very important. The immunocompetent persons also can get the infection. There are a wide spectrum of clinical manifestations from asymptomatic pulmonary infections to acute or chronic disease of the lungs to disseminated infections. It can be asymptomatic in healthy individuals with low levels of exposure, but in healthy individuals also, if the exposure is very high, they can get infection. So symptomatic in immunocompromised or after high level of exposure. So it is endemic in Northern America, but there are some other areas in American continent where the infection is endemic. Natural habitat is soil enriched with bird or bat droppings under bird roofs or bat caves. Birds are not infected, but droppings are primarily nutrient source for organisms in soil. Bats can be infected and distribute the organism. So this is how we can get the infection as Sri Lankans. So you can see the worldwide distribution. Again, Sri Lanka is not colored. It doesn't mean that we don't have the infection. It says that we have no data or numbers. So these are some of the publications we have done about this infection. So this clearly shows that we have the infection. Epidemiology, mode of infection, inhalation of spores, incubation period 1 to 3 weeks, and reinfection 4 to 7 days. It's not a contagious disease, but person to person can transmit from organ donation. So major risk factors are high inoculum exposure, immunocompromised patients, extremes of age, and high virulent strains. The risk depends on the nature of the environmental site, activities performed, duration or degree of dust or soil exposure. Longer and more intense exposures can cause severe pulmonary disease. There had been outbreaks exposed to sites contaminated with organisms or following activities that disturb accumulation of bird or pet droppings. Progressive disseminated histoplasmosis. This is the most common endemic mycosis among patients with underlying cell-mediated immunological defects like HIV, solid organ transplant recipients, stem cell transplant recipients, and patients with hematological malignancies, and so on. In immunocompromised patients, higher case fatality rate is there due to late diagnosis. With HIV, this has become an important opportunistic disease in patients living in endemic areas or resource-poor settings. So this applies to Sri Lanka as well, because our number of HIV patients is going up. So it is very important to us to see whether they are having histoplasmosis or not. All latent foci can reactivate. Outbreaks can take place due to direct exposure to the organism. Prevalence decreased due to introduction of HAART to HIV patients. Disseminated histoplasmosis, it's uncommon in transplant recipients, even in endemic area. It can occur as primarily infection, reactivation of the latent foci, or donor-transmitted infection. And also it is reported among patients with tumor necrosis factor blockers, inflammatory bowel disease, and patients with skin conditions. Pathogenesis, infection begins with the inhalation of microconidia hyphal fragments, because this is a thermally dimorphic fungi, so both can be there. Mycelial form can transform into yeast form in the alveolar macrophages because of the body temperature. And these yeast cells are phagocytes by the host immune system, and this organism is able to survive phagocytosis. Calcium binding protein 1, a cytoplasmic enzyme, and peroxisome enzyme is there. So because of that, apoptosis of infected macrophages allow this organism to spread. And this infection is usually self-limiting in immunocompetent individuals. Clinical manifestations. There are a broad range of presentations. Signs and symptoms include mediated by the host immune status, with immunosuppressed patients being at higher risk for more severe disease. Other factors that play a role in sensitivity of the disease include virulence of the fungal strain and the amount of inhaled inoculum, the fungal burden. Most often, individuals will be asymptomatic, but 1% will present with symptoms associated with the infection. So there are 3 main clinical forms: acute pulmonary disease, disseminated disease, and chronic pulmonary histoplasmosis. Initial site of the infection is lungs. From that, hematogenous dissemination during the first few weeks after the exposure can take place. And after that, it can remain latent, and symptomatic infection can be seen after months or years after the initial exposure. Moving on to acute histoplasmosis, symptomatic patients present 1 to 3 weeks after the exposure. They can present with fever, chills, dry cough, chest pain, myalgia, headaches, like flu-like syndrome. No specific imaging findings can be seen, but often mediastinal lymphadenopathy and infiltrates can be seen. Pneumonia can be seen less frequently, as pericarditis or with rheumatologic syndromes, including arthritis, arthralgias, and erythema nodosum, and mediastinal fibrosis, particularly in patients with HLA-A2, in whom fibrosis is associated with abnormal host inflammatory response. Bronchiolithiasis and pulmonary nodules occasionally lead to compression syndromes due to the size of the lesions can take place. Nodules, they represent the residual changes of the acute disease and can be seen in radiographs as single or multiple calcified and non-calcified lesions. And these are often described as coin lesions that can mimic and cause concern for malignancy. So these are the clinical lesions. Chronic pulmonary histoplasmosis, typically in older individuals with previously injured lung tissues. It may follow acute pulmonary infection or develop secondary to persistent, slowly progressive disease. Typically a complication of the acute disease. With acute disease, there is a progression of disease from pulmonary infiltrates to fibrosis and finally cavitation of the lung tissue. Apical bullae can also be part of the chronic disease. They can present with fever, weight loss, cough, and dyspnea. Bronchopleural fistulas are a serious complication of chronic disease, and there can be cavitary lesions, and these can be confused with tuberculosis or other mycotic infection, and co-infections are also possible. When they get pneumonia, they can present with productive cough, fever, chills, weight loss, malaise, night sweating, and pleuritic chest pain. Lesions, they are more common in right upper lobe, pleural effusion, uncommon, but pleural thickening can be seen in 50% of the patients. Disseminated histoplasmosis, exposed immunosuppressed patients, but a large inoculum infection can cause severe disease in 29% of the individuals without immunological disorder. So I have seen immunocompetent patients who had exposed to large inoculums and got the disseminated infection. So it is, we have all the spectrum. We have the spectrum of the disease in Sri Lanka. Risk of dissemination increased in patients with HIV/AIDS with the CD4 cell count less than 200. But chronic steroid use and immunosuppression secondary to malignancy are additional risk factors. They can present with fever, weight loss, and respiratory complaints. Clinical findings are lymphadenopathy, hepatomegaly, splenomegaly, bone marrow toxicity, calcified granulomas in liver and spleen, adrenal gland destruction with calcification and central necrosis, which is common. Skin and mucosal ulcers can be seen in 60% of the patients. And multiple organs can be involved: endovascular, central nervous system, gastrointestinal, and suprarenal glands. Since these symptoms are non-specific, even disseminated disease can at times evade recognition, and if not treated, can progress to chronic or latent disease. Radiology, acute pulmonary histoplasmosis, you can see X-ray may be normal, but you will see enlarged mediastinal nodes, diffuse bilateral patchy opacities, airspace shadowing with consolidation involving multiple lung segments or lobes similar to bacterial pneumonia. Pleural effusions are possible but uncommon, as I said earlier. Healing process with formation of histoplasmas, which are well-defined nodules with central calcifications, can be seen. Chronic pulmonary histoplasmosis, you can see nodules, patchy infiltrates, mostly in the upper lobes of the lungs, consolidation and cavitation. Lab diagnosis, specimens, you have to send sputum, bile, pus, bone marrow, lymph nodes, or biopsy specimens in a sterile screw cap container at room temperature for fungal studies. Direct microscopy if you are suspecting histoplasmosis, not suitable to do because it is a hazardous organism for laboratory workers. Histopathology is cells consistent with histoplasma can be seen in tissues. In AIDS patients, abundant organisms in peripheral blood smears and bronchial washings can be seen. Culture is the gold standard in diagnosis. Also, we can do serology for antigen detection, that is in urine. You have to send the urine sample in ice, and serology for antibody detection from a blood sample. Antibodies are detectable in 4 to 8 weeks after the infection. So, all these tests are available at MRI. Culture, antigen detection and antibody detection. So you can send samples. So isolation of histoplasma capsulatum from clinical specimens remains the gold standard. So isolation is the culture. The sensitivity of cultures for detection of histoplasma capsulatum depends on the clinical manifestations like pulmonary versus disseminated, the net state of immunity of the host, and the burden of the disease. You can see in acute pulmonary infection, antigen detection is the best. Subacute infection is the serology, that is the antibody detection. Chronic pulmonary infection, both antigen and antibodies, and progressive disseminated infection, it's antigen. So now we have antigen available at MRI. So it is done from urine samples. Only thing you have to be careful to send the sample in ice to do the antigen detection. And if you can send us a biopsy sample and also a blood sample to do antibody detection at the same time, we may be able to identify or diagnose these patients. Management, there is a whole lot of indications for antifungal therapy according to IDSA guidelines. So for acute pulmonary histoplasmosis, treatment is usually unnecessary. But if the symptoms persist for more than 1 month, you can treat with itraconazole. For moderately severe to severe acute pulmonary histoplasmosis, you can use amphotericin B, either lipid formulations or deoxycholated, followed by itraconazole. For chronic cavitary infections, itraconazole can be used for 18 to 24 months, but you need to do therapeutic blood level monitoring. But only thing, it is not available in Sri Lanka. Both government sector and private sector, it is not available. For progressive disseminated histoplasmosis, for moderately severe to severe disease, you can use liposomal amphotericin B followed by oral itraconazole for at least 12 months. Or else you can use deoxycholated formulation of amphotericin B. Progressive disseminated infections, for mild to moderate disease, you can use itraconazole at least for 12 months. For lifelong suppressive therapy with itraconazole, when the patients are immunosuppressed patients and the immunosuppression cannot be reversed, who can relapse despite the receipt of appropriate therapy, you can use lifelong itraconazole therapy to suppress the infection. But you need to do therapeutic blood level monitoring. Antigen level should be measured during therapy and for 12 months after therapy is ended to monitor for relapse. But persistent low-level antigenuria may not be a reason to prolong treatment in patients who have completed appropriate therapy and have no evidence of active infection. Moving on to common wrong practices which lead to drug-resistant fungal infections, because I thought of telling these few things as it is important for our day-to-day practice. Treating commensal candida species in sputum or bile cultures. We know that candida is a commensal in our oral cavity, the gut, skin and the vagina. So most of the time, if you see positive candida culture report in a sputum or bile, most of the time, 99.9% of the time, it's the oral commensal flora. So please don't give antifungal drugs for those patients. And treating candida species which has colonized urinary catheters. Now, when the patient is catheterized, you may get a urine culture report with candida. Those are catheter colonizers. So don't ever think of treating those patients unless the patient is having features of sepsis. But that is also now the mycologists say you don't have to treat any form of urinary culture positives when the sample was collected from a catheter. But I personally think if the patient has features of sepsis where there is no other septic foci, we have to treat the patient. But when you are treating the patient, you have to remove that catheter and insert a new catheter. And also, word about treating tinea infections with steroids combined with antifungal treatment. You all, by this time, you know, we have isolated many antifungal resistant tinea infection causing fungi and also some new species as well from Sri Lanka. So all this is because now it is not only confined to Sri Lanka but in other countries as well. But one thing where we cannot overcome this problem is using antifungal preparations combined with steroids. So please don't ever think of using antifungal or antibiotics combined with steroids for these tinea infections or any other skin infections. And also there are candida species and molds colonizing chronic wounds. So don't use any antifungal drugs for those colonizers because if you think, if you get a report with a positive culture from a chronic wound, positive culture for candida or mold, check whether the sample was a deep biopsy or not, or just a swab. Now, if you have sent a swab, more or less it's a colonizer. In those instances, what you can really do is to see whether that to identify the true pathogen, you can send us a deep biopsy from the chronic wound so that we will be able to identify the true pathogen. And also, I told you this earlier as well, you might get culture reports, positive culture reports with the negative direct microscopy report. So in these instances, you have to be very cautious before starting antifungal drugs to your patients because these positive cultures could be environmental contaminants. So you have to be cautious about that. And treating superficial fungal infections without mycological diagnosis is another problem. There are superficial fungal infections other than tinea infections. So it is always better to have a proper diagnosis, laboratory diagnosis without starting antifungal therapy. Using red light antifungals unnecessarily, especially in the private sector, we have to be very cautious about this because nowadays Sri Lanka is heading for a huge problem because we see a lot of antifungal resistance among our isolates, true pathogens. So we have to be very cautious about using antifungal drugs because unlike antibiotics, we have very few antifungal drugs in the world, and among them we have less than, I think, 10 antifungals or 15 antifungals in Sri Lanka. So we have to be very cautious when using or prescribing antifungal drugs because of this resistance problem. Take-home messages, rhinoorbital cerebral mucormycosis or pulmonary mucormycosis. Start antifungal treatment when clinically suspected. Please don't stay until you collect your samples or do your bronchoscopy or whatever it is. At the moment you suspect clinically, start antifungal therapy and amphotericin B. And continue antifungal treatment with clinical and radiological evidence, even if initial laboratory reports are negative. This was seen in few patients last year and this year as well, where clinically and radiologically they were having mucormycosis, but when the samples were sent to the laboratory, both direct microscopy and culture were negative. So we were also, and the patient had risk factors. So we were also a little bit reluctant to issue the report, but to see first 1 or 2 samples was like that, both direct microscopy and culture were negative. But when the 3rd sample came, both direct microscopy and culture were positive. So if you have clinical suspicion or clinical features plus radiological features of mucormycosis, it could be rhinocerebral pulmonary or whatever it is, please continue antifungal therapy and the other therapy, supportive therapy. You have to manage your risk factors and debulking if it is possible and so on. Until you get a proper laboratory report. Sometimes direct microscopy and culture reports are negative, but histopathology is positive. So it's like that. So don't stop your antifungal therapy when you see a negative report. If you have got all risk factors and clinical and radiological evidence. Start antifungal treatment for pulmonary mucormycosis patients, even if they are clinically stable at the time of diagnosis. I have seen few instances where whenever we issued the report also, some of our colleagues, they were a little bit reluctant to start antifungal therapy, saying that the patient is clinically stable, walking, talking patient, this can't be mucormycosis. But ultimately, that patient died due to bleeding after some time because these organisms are angioinvasive. So they invade the blood vessels very fast. So by that time, we have nothing to do. So when you get a positive report, direct microscopy and culture, especially direct microscopy positive report, culture could be negative because to get a positive culture should be, the organism should be viable. So culture could be negative. Direct microscopy positive report with positive findings in your bronchoscopy. Please start antifungal therapy. And also the HRCT findings will help you all. So we can save the patient, otherwise we would be late by the time we start antifungal therapy. Remember, we have histoplasmosis in Sri Lanka, but yet underdiagnosed. Thank you.
Thank you, Primali. If you can just see the Q&A, there are a few questions to answer. How long should amphotericin be given? After amphotericin, do you need to give maintenance therapy with an oral antifungal like posaconazole?
No. Now, say for mucormycosis, it depends on the clinical outcome. Say, now, sometimes I have seen a child about 1 year where we have given more than 220 days of amphotericin plus some posaconazole. So it all depends on the clinical response of the patient. So what you need to do is at the time to stop antifungal amphotericin B, the patient should have clinical, radiological, and mycological cure. So that is the time where you can stop amphotericin B. Talking about posaconazole, now, if the patient still nobody has shown where to start posaconazole, but if the patient now say we do repeated debulking and all the time we send the samples to the laboratory, first both direct microscopy and culture will be positive. Then after some time, culture will be negative. That means the organism is not viable, but direct microscopy is positive. So that is not the time to start posaconazole instead of amphotericin and send the patient home. So it is still a gray area when to start posaconazole and to send the patient home. My personal belief is not to start posaconazole, actually to treat and cure the patient with amphotericin until we get the clinical, radiological, and mycological cure. Because we have little experience with posaconazole. So I think it is, and also now, if we start posaconazole, since it's an oral drug, we tend to send the patient home. So then the patient also doesn't know what's happening inside, and we also don't know what's happening inside. So my personal belief is we should treat the patient until the patient is cured with amphotericin B, because and cost effectiveness of posaconazole compared to deoxycholate amphotericin B is also there, because now deoxycholate amphotericin B vial is about 2,000 rupees. So the daily cost is around 2,000, whereas posaconazole it's not that cheap. So my personal belief is we should treat the patient and cure the patient with amphotericin B.
Okay, there's another question. You can see it. How do we treat disseminated coccidomycosis? There have been some cases in pregnant women. Is treatment same in pregnancy?
Coccidiomycosis or histoplasmosis?
It's written as coccidomycosis, that question. Disseminated coccidomycosis.
I don't know whether how they have diagnosed it, because it doesn't come. It didn't came to my lab. Maybe they have sent the samples to overseas lab or somewhere. But only thing is you can give amphotericin B, because amphotericin B can be given during pregnancy, even for preterm infants when they get bloodstream infections, even with candida. Where fluconazole is sensitive also, the guideline says to treat with amphotericin B, because what their argument is, now fluconazole is liver toxic in preterm babies, rather than you can give amphotericin B, and also amphotericin B also you can give deoxycholate preparation even for preterm babies. So for pregnancy you can treat with amphotericin B.
Okay. Another question. What are the indication to use nystatin as an antifungal?
Nystatin you can use for vulvovaginal candidiasis, you can use as pessaries, and also oral candidiasis, oral thrush, you can use as lozenges. Other than that, there are no indications.
And what is the duration of antifungal treatment in esophageal candidiasis in patients with diabetes and HIV?
So, of course, you have to control diabetes, and HIV also you have to give a heart and all. It depends on the CD4 count, and for diabetic patients, actually 10 to 14 days is adequate if the blood sugar levels are controlled adequately.
It's a dose?
Dose could be 200 BD or 100 BD also can be used. If the patient is having severe infection, 200 BD can be given. Otherwise, 100 BD is adequate.
Okay. And so there's another question. I think hope it's the last one. Are there any characteristic clinical features of coccidomycosis and blastomycosis?
Yes, because they all both can get lung infection. So, and also they are non-specific features. So both can be there, and only thing is we have to diagnose it. The diagnostic facilities in Sri Lanka is not that adequate.
So you can't differentiate it then.
Yes.
Okay.
From the signs and symptoms, we can't differentiate because it's like histoplasmosis, because the range of spectrum is the range is there. So it depends all with the immune status of the patient.
Okay.
So you have to do laboratory testing to differentiate those two.
Okay, now there's another question. What is the ideal treatment for resistant tinea infection in groin? Tied with the miconazole and terbinafine.
Ideal treatment, you cannot say an ideal treatment because now there are whole lot of organisms, resistant organisms are spreading, and there are some other new species are also spreading. So what we can do is, ideally speaking, we have to do grow the organism and do antifungal sensitivity, which is not available in Sri Lanka, but I do hope to start antifungal sensitivity for these tinea infections very soon. I have asked for the reagents. What you can do is you can treat with oral terbinafine 250 daily for 2 weeks, combined with itraconazole, oral itraconazole, 100 BD for 6 weeks. So initial 2 weeks you are treating with terbinafine and itraconazole both, and also oral local application. You can use something like ketoconazole, and other thing is you have to advise the patient how to apply it. Now you have to apply 1 centimeter larger area compared to the lesion that you can see, because the organism is outward growing organism. So the lesion what we can see is not the margins of the true lesion. So you have to apply at least 1 centimeter outwards. The circumference should be more 1 centimeter more than what you can see, and you have to explain that to the patient, and also you have to ask the patient to apply in all lesions. Otherwise, they can get reinfection, and also at the same time, you have to treat all the household individuals. So those are the things that we need to do, and also never ever use steroid containing topical treatment.
Now, only thing, when you use both itraconazole and fluconazole, we had to look after the liver as well. No, when you are giving such a large dose for about 6 weeks, because
No,
patients
itraconazole and terbinafine, but
just
2
terbinafine.
weeks, I think for healthy individuals, okay, but anyway, you can't give 6 weeks of itraconazole and 2 weeks of terbinafine and send the patient home. You have to get down the patient at least after the end of terbinafine with a liver function test and see what's
Okay.
happening.
There's another question. Is clotrimazole resistance a frequent finding in tinea infection?
Only thing is now in Sri Lanka we have the local application of clotrimazole. So local application only itself would not work for the resistant tinea infection that is circulating at the moment. So my personal experience is we have to treat with oral antifungal drugs. Topical antifungal drugs alone would not work.
I think this another question you have already answered. The question is, Candid-B is a frequently prescribed cream for skin infection. So that you said not to do Candid-B, you can give whatever.
Yes.
It's a
Yes.
steroid.
Yes.
You recommend us to use antifungal alone.
Antifungal alone, yes, not to combine with steroids. I think now with the with the request of the College of Dermatologists, now the NMRA has stopped registering topical antifungal drugs or antifungal antibiotic topical creams combined with steroids. But still in our market, you can get them. So we should be careful not to use them, because most of the time, once a steroid containing cream is used, when the patient comes to us, you cannot diagnose it as tinea. The whole picture is totally different when you use a steroid. So that is another thing where we are not unable to diagnose whether this is tinea or something else when you use steroid local applications.
I think we had a lot of questions. I think really good that we talk about this thing because people had burning questions. Thank you very much, Primali, for giving this timely and interesting talk today and spending your time on us. And same time, I would like to thank Mr. Dishan Fernando for his support and the Gets Farmers for giving the platform. So we will meet up with the next Senior Registrar Forum in December. Have a good night. Thank you.
Thank you. Thank you.